I'm very pleased to introduce our speaker today, Dr. Sangeeta Ahluwalia. She's new to us here at OSU. She is both an undergrad and Ph.D. alumna of UC Berkeley, where she received a Ph.D. in health policy. She also has her MPH from UCLA. She has very interesting experience. She's been a visiting researcher at the London School of Economics and done a postdoctorate at the Yale University School of Medicine. And her research focuses on care for older adults and adults with multiple chronic illnesses across the whole spectrum of health services, ranging from primary care through palliative care up to end-of-life care, which is her topic for today. And her research has been published in excellent journals. It's been funded by the VA Health Services Research and Development Service, and she currently has a Career Development Award from the National Palliative Care Research Center. So we recruited Sangeeta from UCLA a year ago. We're just really thrilled to have her as part of our health management policy group here at OSU, and look forward to hearing your talk.
Thank you. Thank you for inviting me to talk today. Jeff gave a little bit of background already, but I'll just say that I consider myself primarily a health services researcher. My work centers on improving palliative and end-of-life care for older adults with advanced illness. And most recently, I've been focused on improving advanced care planning communication. So that is communication between patients, caregivers, and healthcare providers about the types of care that you would want at the end of your life and your preferences, your values, and your healthcare goals. So I want to start off by pointing out that end-of-life care is becoming more and more relevant these days, ironically, as we do a better and better job of extending our life. And what that's meant is that as we live longer and longer, we have this sort of extended period of decline and dying where we receive a lot of medical care. And it's really up to us to start to think about, as early as possible, what kind of care do you want to receive during that period? How much of it do you want? Where do you want to live? Where do you want to die? Most of us don't think about that ahead of time. So how do we die, and what does that period near death look like? So this was actually done by June Lenny and Joanne Lin. They used a community-based cohort across 4 regions in the United States, and they characterized trajectories of dying. You'll see terminal illness, which is primarily cancer, which tends to be, after diagnosis, a period of relatively functional status, so bad, and then a very clear, evident period of rapid decline. With cancer, it's usually easy to tell when you enter, with most cancers, easy to tell when you enter that period of decline. Organ failure, which is usually heart or lung disease, more often now kidney and sometimes even liver disease, as we get better and better at keeping those people living longer, tends to have this very variable trajectory where you go in and out of, it's progressive decline, but you go in and out of acute episodes, usually characterized by hospitalizations. And then frailty, which is dementia and related illnesses. You start off at diagnosis at a relatively low functional status, and you have sort of a period of prolonged dwindling. So with all of these, other than sudden death, which may be the best way to go since you're at lowest risk of medical intervention, with all of these, you tend to have this period of decline where, as I said, you're receiving a lot of care. And more importantly, you're making a lot of different choices about treatments, about interventions, what you want or not want to receive. And again, most of us tend to not think or even know about the wide range of choices that are available to us at the end of our life until we actually get to that point. So I want to start off, I think my title was Challenges, Opportunities, and Realities, and I want to start off with the reality, which is my favorite statistic, that 100% of us are going to die. I know that there are a lot of people working on changing the statistic, and there are probably some in this room that might be close to changing it, but as of right now, 100% of us are going to die. The vast majority of us want to die at home. 70, maybe up to even 80% of people, depending on polling data, want to die at home. You want to die surrounded by your family and your loved ones. As most of you know, what actually ends up happening is the vast majority of people end up dying in institutional settings where you're receiving medical care, you may be hooked up to life support interventions, and only 25% of people actually die at home. So what's this disconnect? What happens with what it is that we say we want and what we actually end up receiving? That brings us to challenges. So part of it might be that it's very difficult to actually know what it is you want in the future. So maybe we say we want to die at home, but maybe when it comes down to it, we don't actually want to die at home. We want to die with a lot of things being done, or maybe we don't actually want to die. So there's been a lot of research in this area. It's not what my work has focused on, but it's pretty well established that people cannot predict ahead of time what it is that they want. So a study out of UC Irvine by Dr. Ditto looked at it was also, I think, 400 older adults, 65 years and older, a community-based cohort. And he asked them, I think, 4 times a year, or maybe 6 times a year, what their preferences for life-sustaining treatment are. And what he found was what he refers to as a hospitalization dip, that when a person goes into the hospitalization and they came out of that hospitalization, and then they were asked their preferences for life-sustaining treatment, their willingness to undergo those life-sustaining interventions was lower than it was before they went into the hospitalization. So there was a context of the hospitalization that actually changed their preferences. And what was more interesting was that if you went to the interview after that, so a few months after the hospitalization, those preferences went back to the pre-hospitalization level. In other words, they went back to wanting life-sustaining treatment the way they had wanted it before they went into the hospitalization. So there's probably plenty of reasons for that. Maybe they forgot what it was like to be in the hospital. Maybe something changed in their life. But the point is that your context is really going to change the choices you make. And you can't always know that context ahead of time. We also know that the complexity of different scenarios makes this inconsistency in preferences even more stark. So my mentor at Yale actually did a study that asked a similar question of another community-based cohort. It was a smaller sample. And she asked it over multiple time points over 2 years. And so she found something similar, that there was a lot of inconsistency regardless of your health state. So if you were in good health or you were in poor health, people would go back and forth between being more or less willing to undergo high-burden therapy in order to avoid death. But that inconsistency became even greater when they were asked if they were willing to risk cognitive or physical disability in order to avoid death. So you threw in another factor about, do you want to risk some sort of disability? And then people actually wavered even more. So those are actually real scenarios that will happen to you and that could happen to you, and that make your decision-making process really complicated. So bottom line, people have done this research. It's too hard to know in advance what it is that you really want. Asking people in advance to make decisions about their future care is tricky. Here's another challenge. Those studies all are sort of predicated in sort of the clean world, which is what most research is. It's predicated on the fact that they were actually asked what their preferences were. What we have found is that more often than not, people actually never are asked this. This sort of conversation doesn't ever actually come up, or it comes up very, very late. So we did a study of patients who were hospitalized for heart failure. They have higher mortality. And we wanted to know what happens when they go in for their post-discharge follow-up visit in the clinic. Do they get asked any of their preferences? Particularly since we already know that hospitalizations and certain key life events can change your preferences. So what we did was we audio recorded their post-discharge follow-up visit. This is the visit they have right after their after they get out of the hospitalization. And it's really designed to sort of follow up what happened in the hospitalization. Here are the treatments you received. We're going to put you on this now. We're going to manage it this way. We looked at only at older adults, and we did a qualitative content analysis. And so what we coded was patient-initiated statements. So I am of the mind, and a lot of people are, that physicians or healthcare providers should initiate this conversation. But we said, okay, we know that there's not a lot of time in these visits. We know that physicians don't get paid to do this. Let's give them some credit and say they don't have to bring it up. But what happens if a patient brings up something that could be an opener to this sort of conversation? Does the physician follow it up? Do they actually ask them questions about what their preferences might be, what they know about their prognosis, how they felt about the things that happened to them in their hospitalization that could then inform what happens to them in a future hospitalization? So what we did was we coded patient-initiated statements relevant to future healthcare needs. And I'll give you some examples. And then we coded how physicians responded to those. This was a VA population, so this is a typically VA, almost all male. This was in Chicago. It was a higher percentage of black than sort of national samples of VA patients, and 71 years old was the average age. So these were the sorts of patient-initiated statements we coded. And we coded 25 of these unique statements. So patients had made expressions of fear or hopelessness regarding their death or decline. So this patient says, I made 72 on Sunday. I just have to make it to 73. I have to make it. So this is a patient, again, don't forget, who's just been out of the hospitalization for their heart failure. Some patients actually asked outright about their prognosis, about my weak heart. When will it get better? This is a particularly interesting question because in heart failure, your heart actually doesn't get better. So there's already some sort of misinformation that is clear. And then some patients express preferences for specific heart failure-related treatment. We didn't code it if it wasn't related to their heart failure. Sometimes these patients were talking about their diabetes. But this, for example, I didn't want to take the Coumadin. You all fought me to get the Coumadin. I was going to take it, but my wife died, and I finally gave in to taking Coumadin. But I don't want it. I mean, that's a complex statement. There's a lot of stuff going on in there. That could really be an opener for why don't you want to take this? What are your preferences? What's going on with you? We found that out of these 25 opportunities, 84% of them were missed by physicians as opportunities to talk about advanced care planning. So these are some examples of how they were overlooked. Sometimes the conversation just ended or the topic changed. So here the doctor's talking about this patient's diet. How can we improve your eating? And the patient says, can't. And the doctor says, not even if it's really important for your health. Patient says, it doesn't matter. You're going to die when you die anyway. So you might as well enjoy it while you're here. A good opportunity to talk about this patient's prognosis. What does he mean about you're going to die when you die anyway? What does that mean for their preferences for their care? Are they depressed? Doctor says, well, we're going to need to do an x-ray of your chest today because I got to see what's going on with this pain back here. So this is just changes the conversation. We saw what we termed denial, which was sometimes just sort of flat out overriding expressed patient preferences. The doctor says, good news, the interventionalist agreed you're a good candidate to have a staged PCI, which is an angioplasty, as an alternative to the bypass. Patient says, I don't know, I don't want to do it. Doctor says, I feel pretty strongly that we should do something to open up your arteries. Medical therapy is good, but it is not as good as an intervention. Does that make sense? And the patient says, yeah, I guess. And then the doctor says, I think the sooner we get moving, the better. You're not going to argue too much, right? And the patient says, I was about ready to say no, nothing, leave me alone. I mean, that's a pretty strong statement of, I don't want this done. And the doctor says, let's at least get this done. Then you can tell me to leave you alone. Now, the angioplasty is probably indicated for this patient, but for me, that's beside the point. The point is that the patient is expressing a very strong preference for not having an intervention. And this is a real opportunity to ask this patient to dig a little bit deeper into what his preferences for care are, what are his values, and what are his goals. What is he hoping to get out of being treated for heart failure or not being treated for heart failure? And then sometimes we saw hedging, which is relatively common. Other studies have picked this up also with regards to conversations about prognosis. Physicians have a notoriously difficult time talking about prognosis. So a patient says, to be honest, with a disease like heart failure, life expectancy is very short, isn't it? So a very clear request. And the doctor says, yes, because for all diseases, especially with the longer heart when they're very advanced, there's an important organ that's failed. I cannot tell for sure, but... And the patient says, so that means I can go any time. So he's pushing, he's asking. And the doctor says, with a normal heart that doesn't have any problems, if you have an infection, you have a good reserve. So for you, if you have an infection, you have any problems, that can make you worse. I would say that. I cannot tell you numbers, but it's usually 1 to 2 years. So before he says 1 to 2 years, this is a somewhat confusing conversation. I'm not entirely sure what the doctor is trying to convey. But often with the question about, you can go any time, I don't have much time left, the patient is really getting at something deeper than, give me the numbers. And some of it is definitely give me the numbers. But this is a real opportunity for the doctor to have said something more about, what is it that you're thinking? What is it that you're feeling? If this is 1 to 2 years, what's down the road? This conversation ended, actually, right after this. So we find, probably not surprisingly, that communication about planning for your future care is pretty limited in practice. Even when patients raise concerns themselves, physicians often miss these opportunities. So some more challenges. Here's another challenge. So I think most of us should know, advance directives are not very helpful. And I'm going to go through some of the reasons for that. One is that they're poorly documented. So if you fill out an advance directive, it's either not documented in the medical record or it's not documented in a way that a clinician can find it. We did a single-site pilot study. It was a longitudinal study. We followed patients for 3 years. We did a medical record abstraction. And for our pilot, we took 118 patients who had metastatic cancer. It was colorectal, lung, and pancreatic cancer, so pretty aggressive tumors. And we looked at decedents and non-decedents, people who died in that 3-year period and those who survived. We found that over half of these patients did not have an advance directive. These are patients with very short life expectancy. This is end-stage cancer. And the VA actually does better than non-VA settings, where among the same population, rates are as high as almost 80% of patients with metastatic cancer who do not have a documented advance directive. What we found that was interesting was 81% had some sort of preference documented in a note. So clinicians are actually, for stage 4 patients, might actually be getting this information, but putting it somewhere in a note. It brings up 2 issues. One is, can everyone find that note? So if the primary care doctor is documenting it in his note, and then the patient gets transferred to the intensive care unit, can the intensivist find that same note and use it? The other issue is, or the question it raises is, why are we documenting preferences that are not in an advance directive? This gets to another challenge, and why I think advance directives are really not helpful. They're usually too narrowly specified to usefully direct care, or to support surrogate decision making. In other words, they tend to specify very specific scenarios, yes or no questions, they're checkboxes, and they're very hard to apply those checkboxes to the sort of range of nuanced circumstances that happen in actual clinical care. And they don't give any information about why patients actually picked the boxes that they picked. So it's hard to help surrogates say, well, he picked, he didn't want any life support, but it doesn't make sense because he kept talking about how he doesn't want to die and how he wants this and he wants that. There's no information about the underlying motivation, the values that a patient might have held that motivated them to pick a certain choice. So I took a look at the Oregon. I'm used to looking at the California Advance Directive. I took a look at the Oregon Advance Directive. It's not dissimilar. I just want to point out a couple things about this. So this is what I mean about the sort of checkboxes. It's you want to receive something or you don't want to receive it. There's nothing about I want to receive it if, or I want to receive this but not this, and this but not this. So here's one when you just take a look at it. Close to death. If I'm close to death and life support would postpone the moment of my death, then you pick one of these things. What is close to death? Close to death is really hard to define, right? And are we talking time period or are we talking about how we feel close to death? Do we feel like we're close to death? Are we done? Or there are patients who, clinically might be considered close to death, maybe weeks, days, a month, but who don't feel like they're close to death and might make very different choices. Here's another one. I want any other, so that or tube feeding from other life support. And then they say, I want any other life support that may apply. There's no way to specify what kinds of life support do you want. Do you want hospitalizations? Do you want antibiotics? Do you want your vasopressors? Do you want things that might keep you comfortable from symptom management as well, but happen to actually extend your life as well? Another one. If I have a progressive illness that will be fatal, and the illness is in an advanced stage, and I am consistently and permanently unable to communicate, swallow food and water safely, care for myself and recognize my family and other people, and it is very unlikely that my condition will substantially improve then. Now, I've heard a lot of people say, I don't mind if I have trouble eating and drinking. I don't mind having a gastric tube placed, as long as I can still see my granddaughter, As long as, some people say, as long as my family members have the time they need with me before I die, I don't really care about what interventions I'm on. Some people say if I can't talk, then that's it. I want to go. right? I mean, so there's a whole range of different situations, and this might change also, right? So the other thing about an advance directive is for it to be effective, it's really dependent on you consistently updating it, right? So it might change. You might say one thing before you have kids, and then everything might change after you have kids. And most people tend to not go back to their advance directive. I'll point out that the PULSE was created here in Oregon, which is, I would say, a substantive improvement on traditional advance directives. These are actually medical orders, so they can be translated directly into practice. And you'll see in Section B, well, they separate CPR first, and then you'll see in Section B, they really describe a little bit more nuance than the advance directive does. I'm not going to go into this a whole lot. It's being evaluated in different ways right now. There's a small group at OHSU that works on this. Some of the issues that have come up with the PULSE that some of us know here is how it gets transferred. It was really meant to be a transportable document, so you could take it from your home into your nursing home, into the hospital. But I think there have been some issues with how this gets transported and how it gets used in different settings. So how it gets used in the field and how it gets used in inpatient settings. I'm going to set that aside right now in the interest of time, but we can come back to it if we want to talk about it. One more challenge, which is related to the fact that advance directives are too narrowly specified. Relevant information about the patient's values are not generally available. So we did provider focus groups, and we asked them, this was also in the VA, we asked them, what kind of information would help you in your decision making? This was part of a larger study. We asked a whole bunch of other questions around barriers to advanced care planning communication, but I'm just going to focus on the advanced care planning information that providers said they needed. It was, again, a qualitative study, and we had multidisciplinary groups. So we had, intensivists, geriatricians, primary care doctors. We had doctors, nurses, social workers, and chaplains. We had some folks in there as well. So we sort of wanted to get the gamut, the whole care continuum. And again, I'm just focusing on one small piece of the results. They said that one of the biggest challenges was that they lacked useful information about patient values to guide decision making. So this hospital doctor says it's a box they have to check, right, referring to the advance directive. So the guy says, do everything, and you say, all right, sir, that means full code, right? And they probably didn't mean chop my head off and put it in a freezer or everything. They mean some sort of realistic goal, right? I want it if I can go back to some sort of quality of life, whatever that quality of life is for that patient. There's a whole lot more nuance than just saying do all this stuff. And so they really spent a lot of time talking about this key opportunity of using patient values to guide decision-making rather than having specific treatment choices. Many of them said, I don't want to know a specific treatment choice that someone made 3 years ago, 5 years ago. I want to know what undergirded that choice. And so this ICU doc says, I think actually a value statement. What do you treasure in life? What would you not be willing to give up? Those are the sorts of things that are very helpful to providers about figuring out how far do we go with what we have available. And a lot of them said, we have a lot of things available at our disposal. We can do a lot of things, and it's not covered in the advance directive. So what I really want to know is, if I do this, will this really affect the things that this patient said they were not willing to give up? Or if I do this, would this really affect the thing they said was most important to them? And they also mentioned that having something like a value statement would be really important in helping them talk to surrogates. So a lot of time, family members are there, and they're trying to make decisions on behalf of the patient, but they don't actually know what the patient really would have wanted. And different family members have different perspectives on what their loved one wants because of different relationships they have. And the doctors would say, particularly the doctors and the nurses would say, if only we could refer back to something. Like we could say, we had this conversation with this patient, and back then he said he really wanted to make it to his daughter's graduation. And then we could use that to sort of have a more informed conversation with the surrogate about what the right next step would be. So moving on to opportunities. This is the last part of my talk. I think a key opportunity is actually, and I want to emphasize this, is actually having the advanced care planning discussion. We did a study that showed that actually advanced care planning discussions can support appropriate care at the end of life. And I think that this is really important, that it can support the kind of care that in PULSE we say we want to receive. So this was actually back to that pilot study. This was the full study that we did. It was a national sample of veterans diagnosed with stage 4 cancer. It was pancreatic, lung, and colorectal in 2008, and we followed them till 2011, or until they died, whichever came first. The purpose of the study was to evaluate the quality of palliative care that they received using validated quality indicators. We used chart records, so we did medical record abstraction. We combined it with VA administrative data and Medicare files. So we had really high rates of ascertainment for most of our variables. For this analysis, we used a logistic regression to evaluate the association between having an early advanced care planning discussion and the receipt of aggressive care at the end of life. And I'll tell you what that means. So we used the Earl indicators of aggressive care. So these are validated indicators that describe non-beneficial care. So care that in a population of patients that would not be beneficial in the long run. In other words, patients that are likely to die at the end of these interventions. And there are, we actually created aggregate measures, and there are 4 of them. So acute care in the last 30 days of life, which is any one of those things, an ER visit, a hospital admission, a long stay hospital visit, and dying in the hospital. Intensive intervention in the last 30 days of life. So these are the interventions that you would receive in the ICU most likely, including admission, but hemodialysis, feeding tube placement, mechanical ventilation, or dying while receiving CPR. Chemotherapy, which is another indicator. So new chemotherapy regimen initiated in the last 30 days, or having chemotherapy in the last 14 days. In other words, if you were already on chemotherapy that was not discontinued in the last 2 weeks of your life. And then hospice care, by which I mean having no hospice care or late hospice care, which is within 3 days of death, so very late hospice care. Those are our outcomes. Our predictor was having an early care planning discussion. By early, we meant first month following diagnosis of stage 4 cancer. So I'm not talking about, way back when they were stage 1 or where they were newly diagnosed. So these are patients who have been diagnosed with metastatic cancer, who are going to live anywhere from 5 to 12 months max. We looked for a discussion with the clinician in that first month. We specifically did not include advance directives, not just because of all the problems with advance directives, because often advance directives are filed or recorded without the discussion of the preferences. And we really wanted to know, did you talk to your patient about what their preferences and values were? So we looked for notes that described a conversation about the patient's care preferences. And we also gave credit if you had logged a note of a discussion that attempted to elicit their preferences. So oftentimes, you might have a conversation as a clinician with a patient about their preferences for care, and you might not actually be able to come up with any clear preferences for care. The patient might not be ready to have that discussion. They may not actually know what their preferences are, but we wanted to know that the subject was broached. So these are the patient characteristics, again, mainly male. This is a national sample, so we had a larger proportion of white veterans. We had an even distribution of the 3 cancers, primarily because so this was a decedent cohort. I apologize. This is a decedent cohort. We had 665 decedents out of 719 total in the sample. And of course, we had to look at decedents because we were looking for aggressive care at the end of life, so they actually had to have died. But in the big in the overall cohort, in the 719, we purposely sampled to get equal representation across the 3 illnesses, and so we ended up with something similar in the decedent cohort. You'll see the survival. Pancreatic, obviously, was the worst survival with a mean of 5 months. Sorry, I was trying to remember if this was a mean or a median. And colorectal with the longest, almost a year. About 47% of them had a documented discussion in the first month. So these are some more descriptive statistics. The VA, as I mentioned, does better than non-VA settings with aggressive care at the end of life, primarily, I think, because the VA has a strong palliative care program where you can receive palliative care concurrently with life-supporting treatment. So usually, like when you go into hospice in non-VA settings, you have to give up interventional treatment. In the VA, you don't. You can receive both at the same time. So we had almost 70% with no acute care in the last month of life, 90% with no intensive interventions in the last month. And then chemotherapy was a little different. Chemotherapy, we had 64% who had any chemotherapy, and 40% with none or late hospice. We were a little surprised by that. We thought that number would be a little bit lower. Part of that is because some of them don't go into hospice. They just stay on their palliative care treatment or palliative care plan. And so our biggest finding was really that patients who had communication about their end-of-life preferences in the first month were significantly less likely to have received acute care at the end of life. We didn't find anything significant with intensive interventions or chemotherapy or with hospice. And we had some other interesting findings. Not surprisingly, if you were copay exempt, which is really a marker of insurance status. So in other words, you didn't have to pay a copay for your visits. You had better insurance. You actually were significantly more likely to have received acute care at the end of life. But I think that what this really shows is that having a discussion early on, especially after diagnosis of stage 4, can really improve the type of care that you receive at the end of life, that you are less likely to go into the hospital, to die in the hospital, which is what we say we want to do. I'll end with this slide so I have enough time for comments and questions. Here are some of the opportunities that I'm really passionate about and that I'm working on currently for improving care planning communication. One is the use of the electronic medical record to support structured communication in the ICU. So right now, we've developed and we're implementing at UCLA a computer-aided multi-component intervention to support family meetings. So in the ICU, it's mainly families that do the communication about care preferences because patients in the ICU are non-communicative. And so the care team, the ICU care team sits down with the family and says, what do you think this patient would have wanted? They don't happen that often, or they don't happen as often as they should. And they don't happen in the way that the guidelines say they should. So we've developed an intervention that triggers the family meeting for at-risk patients at admission. That includes a structured template for communication. So really guides the care team as to the things that they need to talk about and has space for documenting key outcomes like preferences that were decided, clinical milestones that might have been agreed upon, dissension among family members, things that would be helpful for continued care of that patient. And then it also includes a way to schedule the follow-up family meeting because oftentimes you'll have one family meeting, you'll wait a few days, things might change with that patient, and there isn't a follow-up family meeting to say, do we want to reevaluate what's going on in our care plan? And then for patients who survive the ICU, part of this intervention includes an alert to the primary care provider, and that might be out in the outpatient setting. More than likely, it's usually a consultant like a cardiologist or a pulmonologist that lets them know that their patient was in the ICU, that the patient survived the ICU stay, and that there was a discussion with the family about X, Y, and Z preferences, and a recommendation to initiate a follow-up care planning discussion. So we're implementing that, and right now we're really just evaluating feasibility among the clinicians and the care team. Is this something that they would use? Because with most most computer interventions and EMR-based interventions, clinicians are being asked to do more and more things. And so we really want to know, are they going to use this, and is this going to be useful in practice? Over the long term, I would really like to evaluate whether using something like this improves bereaved caregiver well-being. So if you can increase the number of family meetings you have and the quality of those family meetings, do caregivers who are bereaved have better well-being 3 months, 6 months after their loved one has died? And then the second opportunity that I'm trying to put together for the outpatient setting are group visits for advanced care planning. And I don't mean group visits where we all sit down and we talk about an advanced directive when we fill it out, but group visits for high-risk patients, so heart failure patients who have been hospitalized, who all have the same illness, and to sit and talk about what their values and preferences are. I don't think that the focus should be on completing an advanced directive. I think that the focus should be on priming patients to think about what's important to them so that then they have a follow-up visit with their primary care provider where they can talk about those values and preferences in the context of their specific illness trajectory and then move forward in making more informed decisions. Ideally, something like this would be, rescheduled or held again after major events, so after another hospitalization, after an ICU stay, you'd come back and you'd be able to reevaluate in sort of a focus group or group therapy setting what your values and preferences are. So that's in the works. I'll skip that, and I'll end here. And if there are any questions or comments or discussion, I'd be happy to entertain that now. If there's nothing, I can go back and talk about policy. But yeah. Yes. So I think that So we tried doing this right before I came here with a psychologist, and we had a nurse available for patients who actually had clinical questions. I think a social worker who was trained in this sort of setting would be appropriate and more cost-effective. We just happened to have a psychologist who was interested and available. But I think those are not usually, you don't usually have a psychologist dedicated to an outpatient setting. I've had people tell me that you have to have a physician there. I think that having someone with some clinical knowledge like a nurse available is important. But I really would imagine, or what I really envision, is a group visit that's not focused as much on specifics of a person's illness, because it's a group setting, but things that are important to them and the way they live with their disease. But I do think that the group visit has to be connected to an individual visit with a provider to talk about what you've discussed in that visit and how that applies to your specific illness. Does that answer? Okay. Yeah.
Yeah. Well, I have a question kind of about the pulse. I'm mostly familiar with the pulse, and what I found is physicians tend to have a really good elevator speech for each one of them. They've got it down, they can explain really clearly what the implications are. You might not want to recover the cardiac arrest, but you might want to get to, because you might just get dehydrated. So,
right.
And is that the same for the advanced care directive, where you have people, first of all, that's question one, and second of all, what I've noticed is a lot of hospital facilities aren't allowing PCPs to be attending physicians, so if people wind up in the hospital, you don't have somebody from the outside coming in and being able to give direct communication to the emergency care team at the hospital. And I found physicians to be really frustrated with that. Does that have an implication for long-term care for people?
So let me answer the first question first. I think advanced directives are different than the PULST. I think that the way advanced directives have evolved over the last 15 years, 20 years, are such that there usually is not a good conversation that goes along with the advanced directive. Partly it's because the advanced directive is not detailed enough to actually engender a detailed conversation. Partly because it's been around so long, and I think a lot of providers are a little disillusioned with it and don't really want to deal with it. And partly because in the beginning, there was such a push for everyone to get an advanced directive. I mean, when you go into a hospital, technically you have to have an advanced directive on file. That doesn't usually happen, but you're supposed to. And so it's sort of become a mechanized process. So they will delegate it to a social worker or a nurse, or even sometimes an MA who will say, fill out this form, and then we'll bring you in. So I don't think that, I don't put a lot of faith in the advanced directive as a way to support good communication. I think the PULST, and like you said, does engender better communication. But I also fear that writing things down in a structured way tends to structure the conversation. And sometimes you structure the conversation so much you lose the nuance that you really originally intended to get out of having a good document. So while I think documents can support communication, I feel like improving communication about advanced care planning has to happen separately from the documents that we use to actually record what comes out of those conversations. And to answer your second question, so I didn't quite hear the first part of that, but I think you're referring to outside physicians not being able to come into the hospital, the patient's primary care provider not being able to come in and have that communication. So I've tended to work in settings, I've worked at VA and Kaiser, and so I have not encountered that in my personal experience. We don't really get outside doctors coming in. But I've started to do some work at OHSU, and I've heard that as a big frustration. And in implementing what we're doing at UCLA, that has actually been a limitation of what we've been able to do. So right now we're evaluating feasibility of that intervention just among staff physicians, which are about 15 staff physicians. But they've got about 30 physicians who come in from the outside who are taking care of their patients. So they have an open ICU, so they actually let those other physicians come in. But you're right. I think that could be a big barrier because a lot of people say that the person who should be having this conversation is the provider who knows the patient best. It's not necessarily your ER doctor who sees you. And so I think the way around that is really figuring out a way to communicate back to the primary care provider, particularly like, for example, with our ICU intervention, people who survive that admission. When they come back out of the ICU, people who are taking care of the patient on a regular basis need to know that that patient has come up and they need to be encouraged to do something about it, to have a follow-up conversation. Yeah. Is that sort of get it? Yeah. Yeah. No, you. Oh, I didn't. Sorry.
My question is, are there places that use some other narrative or audio recording or some transcript of what the conversation was, so when the time comes everybody has that and can get at the nuance that you're talking about?
Yeah, that's a good question. So there's actually a program out of Madison, I think, which is Wisconsin, and it's the Respecting Choices program. It comes out of Gunderson Lutheran. And it's a very comprehensive, trained social worker facilitated discussion about care preferences. So the social worker who's particularly trained to have this conversation sits down and talks to the patient and the family about their values and their preferences. And they have a documentation component to it. And so they do document some of that. That program is, I think, fairly successful and pretty comprehensive. It's proprietary, so it's been hard to expand its use into other settings. And because they're still evaluating it in different settings, they kind of hold on to it a little bit. But I think it has a lot of promise. I think the issue you raised about so that everyone has it, I think is a separate issue and is still a challenge. I think getting information put in a central place where everyone, and by everyone that means EMTs who go out in the field, to the ER docs, or, who see the patient, to the primary care provider, who's informed later on that their patient was sent to the ER, so that all those people who are potentially in different healthcare systems have access to it. I don't think that's a big problem and hard to solve. And I think the Pulse really tried to address that by trying to put this information not just in the provider's hands, but in the patient's hands. There was a lot of talk about this is your document, you hold on to this, you stick it on your fridge. And the idea was really, if the providers can't figure it out and, get the information in one place, then at least the information should just go with the patient, So there's this image of patients being carted into the ER with their pulse, holding their pulse form, their bright pink pulse form. And, and I think that's a reasonable approach. It requires a large educational effort, and it requires patients to take charge of something that most patients don't really want to think about and have to be encouraged to think about and to do. So I think that's still a big gap. Again, I've worked in settings where it's been less of a gap to overcome because of centralized medical records. But even in those settings, even at the VA or at UCLA, where everyone's on the same, electronic medical record, which definitely helps. People are still sifting through all the tabs, on the record, trying to figure out where someone wrote this. And nurses write their notes in a different section than physicians write. And oftentimes the nurses are recipients of this information. And physicians never look at nursing notes. And so the information is in there, but it's not getting around to everyone. So I think you asked, I think your question is really two different questions, and the latter half doesn't really have a solution to it. Any other? Yeah.
So first of all, your study is great. I like it.
Thanks.
My question is about the odds ratio and the implication, the result, especially regarding the odds ratio for acute care.
Yeah.
So, for the status quo, what is going on? The physician may have incentive to induce multi-level the physician act as an agent, and they try to be patient may be incentivized to use more medical care because now they have more information.
Mm-hmm.
But you find this kind of
The opposite?
yeah.
So, yeah.
So my question is that if the relationship you find is causal, that has huge implication for healthcare in general, especially healthcare costs, because that kind of implies that improve could reduce healthcare costs.
Yeah. So
but I think the relationship is kind of
tenuous, yeah. Well, I'll tell you the problem with it. I mean, and it's a good point. I would argue that this does have a lot of implication for healthcare costs. And this study that we did in a veteran population, but something similar to this study has been done in a non-veteran cancer cohort, community-based cohort, and they came up with similar results. So I think having two big studies out there that say this really say something about what we can do for our healthcare costs. Obviously, politically speaking, it's hard to say, if we talk to you about the end of life, you'll pick less care and it'll be cheaper for all of us. And that's really not the goal, right? I mean, that might be an unintended consequence, but at least from my perspective, the goal is not necessarily to reduce costs, but really to give the patients the kind of care that is more beneficial for them, that can result in better quality of life, that we say that we want. But the problem we have actually we do have an endogeneity problem with our results, which is basically that, and it actually goes a little bit opposite the way you said it, but it's still an endogeneity problem, that there is something about the patients that is getting them that advanced care planning conversation early, right? There are some patient characteristics, something about the patients that's signaling to providers or signaling to the patients themselves that they need to talk about this early on in the course of their illness. And whatever it is that is getting them to have that conversation early is also associated with the fact that they're getting less aggressive care at the end.
I think that patient who manage, their needs for healthcare or others better than others, kind of proactive. Really engage in
Yes.
Conversation with physician.
Right.
So I think if you can, in the future study, if you can push for that.
Yes. Yeah. So I mean, yeah, we don't know who initiated the conversation. We don't know if it was a patient who said, "Hey doc, I'm dying of cancer, we need to talk about this," or if it was a doctor who said, "Look, we really need to talk about this." Even if it was a doctor who said it, there was probably something about the patient that's signaling to the doctor. Above and beyond the fact that these are metastatic patients, that's signaling this patient in particular needs, an early discussion. We control for survival and we control for type of illness. So for the more aggressive cancer, like pancreatic versus colorectal, we control for comorbidity. So we sort of controlled for illness characteristics to sort of get at, are they talking to sicker patients among this already sick cohort? We also don't have content of the conversation. So we don't know what the doctor actually said. We don't know if the doctor was sort of like, look, you've got, only a few months left to live. It's probably not going to make a lot of sense for you to get a whole bunch of treatment. It's, we have no idea. They might say, oh, we can really fight this. We're going to get this, we're going to get this cancer. So we don't know what was said in the conversation. So for sure, we have an endogeneity problem, that there's something about these patients there's potentially something about these patients that are not only getting them the conversation early, but are also getting them less aggressive care at the end of life. We tried to control for as much as we could. I still think, though, given inherent endogeneity, whatever it was, there is still this association between having this conversation, whoever initiated it and whatever was said in it, and having less acute care, significantly less acute care at the end of life.
You have data from multiple sites then?
We do.
The institution characteristics?
Yes. Yeah. We actually, yes. Yeah. We tried this with an IV model, too. It was, anyway, so yeah. Yes. Yes, Bridget.
This is not your content or your age group, and so you can just say, I have no idea.
Okay, I don't have any idea.
I'm going to talk about kids, right? So we think about terminal, like kids who have terminal cancer. And I would think that from that perspective, they will have themes of helplessness, particularly because of their age, and how you sort sort of see this, or has it been applied to that sort of setting where the kids and the family members or guardians all have a conversation together instead of the child potentially feeling like things are just being done to them?
Yeah, that's a really good question. Pediatric palliative care is a limited but fast-growing topic, sadly. I don't do any pediatric palliative care because I think it would break my heart. But much of the work that I've seen in pediatric palliative care has really focused on communication with parents and not with children. And it's focused on helping parents. And the work is focused on, like, the palliative care has been focused on how do we help parents cope and how do we help them grieve. I think there is a real lack from what I've seen of how do we involve a child, or what is the right level of involvement for a child, and what ages and developmental groups are we talking about. But because my work focuses mainly on communication about decision-making, with minors, obviously the decision-making is with the parent. And so pediatric palliative care has tended to focus on the parent. It's probably a big area that needs to, I think it's a really big area. I actually went to a conference once where I remember it was a palliative care conference, and I remember thinking, gosh, there's so little in pediatric palliative care. I bet my career would really move forward if I did something in this area. But it's just too hard, so I haven't done it. But, yeah.
Well, I know better than to do this, but
I know.
the juxtaposition of the reduced intensity for people who have care plans and the increased intensity for people who have no financial disincentive was striking. And we know from other settings that a lot of people refuse care because they don't want to burden their families with potentially bankruptcy due to this sort of thing. Can you speculate about how much of advanced care planning has to do with, I don't want this stuff because I don't want to hurt my family?
I think a lot of it, I think a lot of it is I don't want to be a burden to my family. And that's not just financial. It's I don't want to be the person that, my daughter is going to have to take care of me. She's got her own family. And I think I actually think that's a valid value to hold, a reasonable value to hold, or an understandable value, and that is an appropriate value to guide your healthcare decisions. The purely financial, I think, still has to be teased out. Are you making this purely because you can't afford the care? With the VA, that's not so much the case, right? Because they're covered. So this copay exemptions is negligible is kind of a strong word, but it's not really the driving factor. But I think that it makes the result even more striking. That even in the VA, there is obviously this sort of financial disincentive, and what can we do to change that, or do we need to do something to change it? Yeah, I agree. Yeah.
Sort of following up on that, is the copay, I understand the copay exemption in VA is associated with low income.
Yes, lower income people qualify for a copay exemption.
So were you able to control for education, or?
We didn't have education. No, we only had race, we only had race and marital status. We didn't have income. We didn't have education.
So it sort of makes me wonder
if
in that VA setting, that variable may be a proxy for
something else, like
ability to
understand what you're receiving, or to communicate for your wishes, or to be an advocate, or to have people around you who are advocating. We did control for marital status, so but that's it. But yeah, we didn't have things like social support in there, or it was all administrative data. Yeah.
Sort of along that line then, so whether in the medical record itself, are there indications there of whether or not the patient requires interpreter services as a proxy for language? And I just wonder if then that would...
Yeah. We didn't have language or interpreter status, so we didn't know if this was patient. We didn't have language or interpreter status. I'm trying to think. We had primary caregiver information. We had surrogate information if the patient actually had someone else, but nothing about language or whether how they were communicating. So we didn't have. Really, it gets at how well are you communicating with your physician, or how well is that what does that communication process look like? I agree. Yeah, we did not have that. No.
You said you had education?
We did not have education. No, that would have been good. Yeah, we did not have education. Yeah. Anything else? No? Good. Okay. Thank you.